mechanisms. So let's discuss whether the goals of these guidelines have changed, and let's discuss how to manage anti-anginals. So the goals for the treatment of ischemic heart disease have not changed. We still want to prevent MI and death. We still want to reduce myocardial ischemia, and of course we want to improve symptoms and quality of life. And we have very effective strategies to improve clinical outcomes. We know that lifestyle changes are very important. Stop smoking, the use of statins, the use of ACE inhibitors or ARBs, antithrombotic therapy in the acute coronary syndrome, beta blockers in heart failure patients, and lately the use of LGP1 receptor agonists and SGLT2 inhibitors in diabetes mellitus have shown that these interventions can improve outcomes. And regarding the management of symptoms, the guidelines say, well, the initial choice of anti-anginal drugs depends on the individual patient's profile, the comorbidities, the drug interactions, the other therapies that have been administered, and also the patient preference. When the patients know what are the side effects of the drugs that are going to be prescribed. And they have modified their approach. Now they don't talk about first, second, and third line of treatment. They say, well, if you are going to give standard therapy, we have 3 steps. Beta blockers or calcium channel blockers. Then second step will be to add a calcium channel blocker to a beta blocker. And then if that doesn't work, then you add some of the newer drugs or second line drugs like nicorandil, ranolazine, or trimetazidine, and I'll come back to this in a minute. However, if you have somebody with high heart rate, you will have to choose drugs that slow down the heart rate. If your the patient's heart rate is low, you would like not to make things worse, or you are not going to use drugs that slow down the heart. You rather go for drugs that have no effect on the heart rate. And likewise, if the blood pressure is low, you would like to avoid medications that make the condition worse. So a slightly different approach, in the sense that they say, well, let's look for drugs that actually do what we want them to do in the individual patient. That's why now, for example, drugs like vasodilators like nicorandil or ranolazine, metabolic modulators and drugs will have a completely different mechanism and does not affect hemodynamics, appear now in the guidelines with a recommendation which is set to A. Now, I still have a few problems with the current guidelines recommendations. Although they are a lot better than in the previous guidelines, they don't really articulate the fact that there is no difference in efficacy when you compare anti-anginal agents. What they call first, second, and third line of treatment is not such a thing, because the evidence for the anti-anginal effect of the anti-anginals we have is not better for one or other in the clinical situation. And on the contrary, for the newer drugs like ranolazine, the evidence base for the use of these drugs is a lot better than the evidence we have for beta blockers or calcium channel blockers, or even nitrates. And the other problem with the guidelines is that they do not suggest individualizing patient treatment, except for a few things like heart rate or blood pressure or heart failure. So let's see, how can we apply the guidelines to a real life case. This is a 56-year-old British female CCU nurse who has a 2-year history of central chest pain and dyspnea on exertion, and occasionally also some chest discomfort at rest. The symptoms were getting more frequent. She was completely healthy until 2 years previously. She used to exercise, she used to cycle to work, she used to go for long journeys on her bike during the weekends, She was a little bit overweight. She had menopausal symptoms for 3 or 4 years. She was mildly hypertensive when seen in clinic. The total cholesterol, when first seen at the local hospital, was slightly raised, like her triglycerides. Her vitamin D levels were low. She had borderline HbA1c with a slightly raised high sensitivity CRP. She never smoked, but there was a very strong family history of diabetes mellitus and coronary artery disease. The rest of the systems were okay. Her baseline 12-lead ECG was normal. The baseline echocardiogram again showed no abnormalities, and importantly, there was no pulmonary hypertension, because we were worried about pulmonary hypertension because of the dyspnea. The exercise stress test was positive with ST segment depression at around 9 minutes, with a very good heart rate and slightly raised blood pressure. And she developed the usual symptoms, chest tightness and shortness of breath. So she went for an angiogram. The angiogram showed no obstructive coronary artery disease. She was reassured and started on sublingual GTN and bisoprolol, vitamin D supplementation, diet, regular exercise, and she was given an appointment in clinic 6 months later. When she came back to clinic 6 months later, there had been further deterioration of the symptoms despite the conventional treatment for angina. She had weekly episodes of rest angina now, mainly at night and in the early morning hours, with shortness of breath and chest tightness when she was walking, even on the flat now. And just by chance, when she was in clinic, she developed a spontaneous episode of chest pain. An ECG was taken, and there were ischemic changes on the ECG in the precordial leads. There was no cardiac troponin elevation, and the administration of GTN resolved the pain and the ST segment changes. So she was sent for an angiogram.